Good evening and welcome to Thursdays with NAMI. My name is Peg Morrison. I'll be your host for the evening. I am the Assistant Director of NAMI North Carolina. That's the National Alliance on Mental Illness, North Carolina. I'm glad y'all are here. Thursdays with NAMI is our way of building conversations and really building community around the topic of mental health. Now, if you're involved with community mental health in the system, you hear lots of shocking numbers. For example, there are 10 times more Americans with serious mental illness, severe mental illness in prison and jail than there are in state mental hospitals. Wow. So there are more folks with severe mental illness incarcerated than there are getting help with inpatient care. That's astounding. Can you imagine that happening with any other illness? Heart disease, cancer. Let's put them in jail so the rest of us can be safe and relax. I don't see that. How did we get here? It has something to do with a trend called deinstitutionalization, and we're just going to take a walk down the United States memory lane. I hope if you can see that. So prior to the 1950s in our country, most folks with serious mental illness lived their lives in mental hospitals. Some felt it was a great system. Others thought it was a way of warehousing people. Then a few things happened, and I'm boiling it down to the basics here, of course. First came some dramatic headlines about squalid conditions and abuse in some of the facilities. Second came some new antipsychotic drugs. And these created new hope for folks with schizophrenia, bipolar disorder, the psychotic illnesses with psychotic features. If warehousing was cruel and medication was making life better, why not let people live in the community? This leads to our third reason. It's much more affordable to care for people without the expense of 24/7 hospitalization. So people were discharged, they were let go. Where did all the former patients go? Some of them lived with family, some went to supported housing or group care facilities. Those were the lucky ones. Many ended up in the street and or ultimately incarcerated. So this chart shows the population of mental health hospital patients going down, the prison population going up, and you can see how those went hand in hand. So what kind of treatment is available under lockdown? Our guest tonight is Dr. Tricia Hahn, and she will be filling us in just a moment. As usual, the first part of our show will be an interview with our guest. Partway through, we'll show our video of the week, and then we'll be taking questions from you, members of our virtual studio audience and Facebook friends. Now we've got a quick word from our sponsors. Thursdays with NAMI is funded in part by the North Carolina Department of Health and Human Services, Division of Mental Health, Developmental Disabilities, and Substance Abuse Services through the Federal Community Mental Health Block Grant Fund. We do appreciate their guidance and support. All righty. So now I'm so pleased to introduce Dr. Tricia Hahn. She has an amazing resume. She's worked for the state Department of Safety. At one time, her leadership was over the majority of inmates in North Carolina. She's worked with juveniles. She's worked with folks with bipolar disorder, just a vast array. Worked in the courts, helped establish our drug courts here in North Carolina. I'm so pleased to introduce Dr. Hahn. Welcome and thanks for being here.
Thank you. I'm really happy to be here.
All right. So we always like to know the background of our guests. Tell us your story in a nutshell.
Okay. Well, I grew up in Virginia and I had a pretty happy childhood. My parents' initial start together was very interesting. My father was a CIA agent over in Japan, and he met my mother. This was fairly soon after the war, after World War II. And at that time, people could not, anybody in the CIA could not marry foreign nationals. And it wasn't just because she was Japanese, it was anybody, British or whatever. So my father, I guess, went back to the States and he promised my mother he would come back and get her. And he did, but from what they've told me, it took 2 years. And so they got married. He, of course, got fired from his job, and but then he had a lot of friends, and so he started working for the federal government in other capacities up there. Hi, Gail. and so, and my parents have been married, I think, over 65 years now, and they are in this area. And so that was just a brief, and I have one brother, and that's just a brief background of my childhood. And then in college is when I started getting interested in psychology. I had some excellent psychology teachers, and I wanted to go to graduate school, but I didn't. But at that time, for some reason, to go to graduate school in psychology, you did not want a master's degree. It actually counted against you if you got a master's in psychology. And so I went and got a master's of science in public health instead at UNC-Chapel Hill. And that program just really opened my eyes to a lot of things. One of the things that the program really emphasized is that when it was health education was my concentration, was that when you go to work with people like overseas or whatever, you really try to meet them where they're at. For example, if I wanted to start a birth control program, I don't go over there and then start saying, you know, everybody here needs to use birth control or needs to do this or needs to do that. I actually want to get to know them first, build the relationship, and then find out what they need. So if they need, you know, something to occupy their children or better water or whatever, you start working with them on what is most salient to them, and then go on and do your birth control agenda. And so I did that, and it really, it put my mind in a different perspective when I went to my clinical psychology program. And my program was actually in clinical community psychology. So luckily it sort of meshed with my background in public health, in that it taught us how to work with communities and systems rather than just individuals. And as far as family members with my husband said I could say this. My husband has major depressive disorder. He struggled with it for a good part of his life. He still has a bad sleep component to it. But before we met and married, he had a hard time getting the correct medication. And he finally found a combination that worked for him. And it took a little convincing for the doctors to think, okay, well, this might be a good thing to take. And he finally did. And since that time, his symptoms have been pretty well controlled. It was very much a vegetative depression, where it wasn't situational factors. He would just go into the depressive episodes. So.
Right. Well, it sounds like you have so much in common with NAMI members across the board. So that's wonderful to hear. And I love your comments about meeting people where they are and focusing on their needs as they identify them first. One of the things I'll never forget, one of the first family members I met was a coworker in Ohio who had adopted children with serious mental illness. And she kept telling the providers around her, I need respite. And they kept saying, we have an art class that we'd like to bring to your home and offer to you and your child together. Yeah. They were just completely off. So always good advice, meet people where they are. So moving right along, you have worked in a variety of mental health settings, as I mentioned, Dorothea Dix Hospital, state prisons, youth detention centers, and substance use facilities. What are some of your impressions as you look back on your career? And I should say you retired somewhat recently, earlier this year.
That's right. I retired from the prison system on July 31st. Having worked at the various facilities, because most of these were state facilities. So at Dorothea Dix Hospital, I worked on the forensic unit. With the youth, I worked at that time, it was the Department of Juvenile Justice. So I worked at a youth development center, what used to be known as training schools. And then, of course, in the prison system, I worked in the prison. I started it at Central Prison. But one of the things that really struck me throughout my career is I have just worked with phenomenal people. People who, you know, as people know, you know, if you work for state government, our pay has actually increased. It has gotten better, but you know, originally or whatever, you do not get paid very much for the education that you put in. And yet the people I work with have just been so dedicated, and a lot of them chose to go into this field because they wanted to help people who needed the help, and didn't want to. A lot of people I work with did not necessarily want to go into private practice, and they wanted to work in systems and institutions. So that's one of my impressions. Oh, and another thing I did write is throughout the systems I've worked with, there never has been a dull moment. That's one thing very exciting about the work, especially in the prison system. Many of us have commented that our day just goes boom like that, and then it's over, and the week just speeds by because things are just happening all the time.
That doesn't surprise me to hear that every day would be different and challenging. Absolutely. Okay. So it's been said that 10 times more individuals with severe mental illness are in U.S. jails and prisons than in state psychiatric hospitals. Talk about that. What is the best treatment environment for folks with severe mental illness?
That is a very good question. It's an interesting question. You know, I had actually, when I wrote my answer, I had talked about deinstitutionalization. And what I really liked our system back, I think it was 2001, when we, how do I put this nicely? I thought we had a very, very good outpatient system. And it it worked really well, and I thought it did a very good job of providing services, and there were multiple services. And then they took apart the system and they made it a little bit different. Now, I have not followed the outpatient system that much now, and so it might be fine now. I know that there are many good places, but that wasn't quite deinstitutionalization, but that was one of the things I wanted to mention about the outpatient treatment was so good. So as you pointed out, Peg, what had happened with the deinstitutionalization movement is they decided that people should be treated in the community and not in the hospitals. And part of me thinks I have mixed feelings about that. Interestingly enough, in our state, when working on the forensic unit, there are another group of people who could definitely get not guilty by reason of insanity. They were clearly psychotic at the time of their offense, and almost any jury would have said that. But a number of those I worked with closely decided to go into the prison system instead. And so looking at it from a forensic, I mean, so they had this, state hospital versus the prison. And one thing nice about the prison system, even though it's not the best place for people with mental illnesses, it's not as bad as it sounds, because I think our treatment is very good there. And I think I had that in another question to talk about what we actually did for treatment, but people have a lot of opportunities. I know somebody who had a very serious mental illness, a very serious crime, and he was very young when he went in, but he was very, very psychotic. But then he took his medication, and I think, and that was a number of years ago, he went to classes. There were all sorts of classes. He had jobs. There's just a lot you can do, and he's around a different population. I mean, there are people with mental illnesses. There are people that are completely normal. There are really nice people. There's really mean people, and there's just a lot of diversity and a lot of opportunities. Whereas when you go to a state psychiatric institution, I think you're just a little more restricted. For one thing, it's one hospital, whereas with the prison system, you could go to many prisons, you could get closer to your family, and there are just different opportunities that aren't all focused on mental illness. Mm-hmm. So I have mixed feelings. Oops. Oh,
you're fine.
I was reading that comment there. Unfortunately, these comments look so interesting, but it's hard to read and think and talk at the same time. But so it's just hard to say where people are best, mm-hmm. and where they're treated the best.
Yeah, there is an interesting question in the chat, and I have a question as well. Can you comment on people being in solitary confinement? I'm also going to throw in my question. If I had a loved one in prison, I would just be so worried that they would be victimized in some way by other prisoners.
That is a worry. Certainly we work, we have the Prison Rape Elimination Act, which is PREA, which is the the federal government regulations on trying to stop incidents like that. It happens, but it's interesting. If people are very, very ill, like if they're very schizophrenic, sometimes they're left alone because people are afraid of them. Because they're so unpredictable. I worked with a lot of the transgender individuals, the male to female transgender individuals in the prison, and they were more vulnerable, but most of the ones I worked with felt pretty safe, which I was surprised about. And just in general, I mean, mental illness or not, there are just people that are targeted for some of the abuse that happens in prison. But we do work hard to try to keep our eye on that. And we meaning, well, I'm still acting like I am there, but I am, of course, not here to represent the Department of Public Safety. But I think the prison systems do a good job of that. Mm-hmm. Now, solitary confinement is a really interesting question, because when people think of solitary confinement, sometimes they think about people being in some isolated, dark place away from everybody, because that's what it sounds like. But mm-hmm. what actually happens is that, and some of the places are dark. They are Central Prison was a little bit on the dark side, light wise. But what is interesting, what happens is that most of the time the cells are close enough so that people really have a lot of communication with each other. Even in the HCON unit, the high intensity unit, restrictive housing unit, they talk, they make relationships. Certainly, people come by and check on them a lot. But what most surprises me, and I think that this would surprise a lot of people, and this is sad but understandable, is when we have a number of people who are clearly, seriously, and persistently mentally ill in restrictive housing
Mm.
because they are schizophrenic. They have schizophrenia. And what a lot of them just really want to be there. And there's a chunk of people who want to be in restrictive housing, and it's not a low percentage. I remember we started the federal government wanted to get people out of restrictive housing, and we were thinking, like with PREA, we would eventually have to do something about that. And I would go to different prisons, and I worked a lot with the restrictive housing people, inmates. Just they were my favorite population.
And so is restrictive housing the same as solitary?
Yes, yes,
Okay.
it is. We just don't call it solitary confinement anymore.
Thank
so yes.
you.
But I would have people shout at me, some of the inmates, don't you take me out of here, I want to stay here. And they were angry at the whole idea of going out. And if they were shouting at me, unless I knew them, because I did know a lot of people with schizophrenia, they had reasons, whether it was fear or they just didn't want to deal with, the whole prison thing, why they wanted to stay where they were. Whereas the people who have schizophrenia, their comfort zone is more to be isolated anyway. So they felt comfortable isolated. And sometimes because they weren't out in the regular population, they would not have to necessarily be force medicated because they were alone, they weren't a danger to themselves or others, and they were, in restrictive housing. And so we have some people who just really, they don't give us any reason to commit them to the inpatient unit or to give them involuntary medication. They'd be very dangerous outside, but they're not dangerous when they're in restrictive housing, and that is where they prefer to be. So it's very difficult. It's very interesting as to what to do.
Interesting. I can understand how folks with severe and persistent mental illness might do well not having so much stimulation around them.
Yes,
I can understand that.
That too. And then we do have some very violent people who they would be very dangerous in regular population. Some of them are not mentally ill, of course, and then some of them are. And so it's some people, it's very dangerous to let them out.
Okay. And I want to say to our Zoom audience members and Facebook friends, please type your question. Facebook, type it in the comments. If you're on Zoom, type it in the Q&A and we will get to them. I want to continue with some of our basic questions here. There's so much we can learn from Dr. Hahn. So they say that the therapeutic relationship is the best predictor of a client's outcome. And how do you build trust when a client is incarcerated? And what are those therapeutic dynamics like in prison and jail versus the outside?
That is my favorite question. I think because of my background in public health, where we were trying to see what was important to the person, I think that influenced me a lot. But in most of the work that I did, the most important thing to me was that my relationship with others, and that was with the staff who I worked with, as well as the inmates. And so I would spend a lot of time just building relationships. And for example, with somebody who has schizophrenia, what sometimes happens, you're a clinician, so you start talking about medication and, asking them, are you going to hurt yourself or others? And trying to get them on a certain, to take their medications, to engage in therapy. But and what I usually tell people with people with schizophrenia, I approach it very differently. I don't ask them a lot of those things right away. Instead, I just take my time to build the relationship. So I worked on at the inpatient, originally I was at Central Prison on the inpatient unit with the restrictive housing people, so they were behind the door. But I would go up to them for just brief amount of time, say hi, start, introduce myself. They certainly knew how I was, ask them how they were. But then I would try to focus on something else. I wouldn't always be talking about mental health issues. One person who was very psychotic and did not want to be medicated loved Stephen King. So we talked about Stephen King novels, and we basically chatted. And when you do that, even though they're very psychotic, and some of them, even though they were very angry, they sometimes, I mean, not all of them, they started to form that relationship. And then when you started talking to them about the more clinical issues, they would listen to you much better. And they did start to trust you more. I think one of my most heartrending moments came, I think, right before I was going to retire. And I worked with an individual for a number of years. He was very schizophrenic, very delusional. He thought people would cut up dead bodies and put it in his food and all. And he was very paranoid. And my favorite thing is he thought we were gassing him all the time. And I'm like, we wouldn't do that, because, if we were gassing you, it would come out and get us. And that was always his last delusion. When he did take his medication, he did not lose that delusion. He might have lost the dead body in his food one, but he looked at me and he goes, well, I think we just need to agree to disagree, Dr. Hahn. But he came up to me, this was during COVID, and he was asking about the unit next to me and next to him. And he was wondering if it was for people who were positive for COVID. And he was very worried about that. And I told him, no, it's not for that. Right now, it is a quarantine unit, but we do not have any positive patients there. And he looked at me and he goes, I trust what you say, Dr. Hahn. And if you say that there's no one in there who is positive, I trust that is true. And even now, it makes me just want to cry, because it was, for somebody that paranoid, it just really just broke my heart. And so that's sort of working with the SPMI population. And then when I worked in juvenile justice, I had to do evaluations. I did an interview, I did a WISC with an intelligence test with them, and various other tests. But it was very interesting, because I worked with a lot of young people. They were more, adolescents, and a lot of them were in gangs. A lot of them did not trust adults. And so what I would do is I had an interview, and I asked them all their typical interview questions. And they just sort of give me these one-word answers and all. And then I'd sort of put away the interview, and I'd always try to find a hook. And so if they like dogs, I would start talking about dogs. With one person, we actually bonded over Dodge Chargers. And then we just sort of sit there and chat, and I'd put my interview away, and I wouldn't be writing in everything. And then, 10 minutes later or so, then they'd say, well, I do have this problem, or I do have this worry, and all their mental health concerns that they did not mention in the formal interview would then come out. So it's that whole not always, presenting as the clinician, and just building that relationship. And I have one more thing with that one, because as I said, to me, that's everything, that the relationship is just everything. And another weird thing I would do is when you're in a forensic unit, you end up going to court. and testifying various things. And of course, many people who are arrested for serious crimes, they may try to malinger a psychotic disorder, malinger a disability, fake that they're mentally ill, even though most of the people who are mentally ill, as I said, a lot of them choose to go to prison rather than to take the NGRI. But people use various malingering instruments like the MFAST and the SIRS, where you try to catch people lying. And even, I mean, they're important instruments, but I refuse to use them because to me that was a deception. And I can take things I would give, because you're trying to deceive them, you're trying to trick them in a way, because you're having them answer yes to questions that people would not normally answer. But what I would try to do is I would try to take an instrument I would give everybody, like during the intelligence test, or the MMPI is not designed for malingering, it's designed for a lot of things. And I would be able to see how people, that people who did malinger would oftentimes do things differently. And I used that, but I wasn't using an instrument that is sort of inherently deceptive. And that was because people were, even now in the prison system, when we do assess for malingering, people are always a little surprised at, I don't know the instruments that well because I don't use them. And so that goes back to the relationship, where I really tried never to lie to anybody or misdirect them. Sometimes I would not answer their questions, like if they asked me something that I really by policy couldn't tell them, but I would not tell them lies or anything. And I would also try to do what I said I would do for them. And so I'm not really good at these fancy therapeutic techniques. I'm okay with them, but I really felt that building the relationship really helped with changing them.
I can't imagine anything more important than that. And I can see why the gentleman who believed you about the COVID, being a COVID negative space, I can understand why he trusted you.
Yeah, that was.
So another challenging and interesting area, you were chair of the state's involuntary medication committee. That had to be that had to be a lot to deal with. Tell us about it.
Okay. What happens is Central Prison and NCCIW, the women's unit, they have an inpatient psychiatric hospital, basically. And all the 55, well, it was 55, I'm not sure what it is now, prisons would, if somebody was a danger to themselves or others, or needed a higher level of care, would send them to Central Prison inpatient. And because of that, we got a lot of very seriously and persistently mentally ill people who were very psychotic. And they would stay that way, of course, unless we medicated them. And so because I think we were court ordered many, many years ago. And so we had a formal hearing where we read the patient his or her rights, and then had a formal hearing where we would have a psychiatrist, a psychologist, and I was the psychologist there, and a nurse. And we would, as a committee, we would decide whether that they were approved for forced medications or involuntary medications or not. And so we did this every Tuesday, and Central Prison, the most we had on one day, I think, was 9 people who we had hearings for. So we read them their rights. They have 48 hours to, like, if they want witnesses or anything, and then we would bring them to the hearing into the room. it was very rare when we did not do that, because they, these are people that were very dangerous, but I really wanted them to have their hearing outside, and I mean, not behind the door where there other people could hear, and they had to be, almost imminently dangerous. Well, I mean, that very second to not, because all of them were imminently dangerous. And so we would just talk to them. And in order to see how psychotic they were, it was usually better to give them an opportunity to talk a lot, to tell their story. So we were very patient, listening to why they did not want medication. And then we would have them step out, and then we would decide whether they needed involuntary medication or not. And some of the people were just heartbreakingly ill and heartbreakingly dangerous. And what is very sad, and what I would often tell them, is that if people have schizophrenia and they keep stopping their medication and then having to be given their medication again so they reach their baseline, it gets harder and harder for them to be treated successfully with the medication, and then they have to increase the dose, which means that you've got more of the bad side effects and all. And yet they have a disease where they don't understand that they have a disease. They think that they're fine and that they don't need medication. Because, for example, if I have, I have some pre-diabetes. Now, I know what I have. Now, do I choose not to eat candy? Have I chosen not to go on medication and try to do it by diet and exercise despite eating all the candy? Yes, I'm not saying I'm compliant necessarily, but at least I know what I have. But for some reason with schizophrenia and sometimes with bipolar disorder, the person cannot understand that they have the disorder. And so they won't take their medication, and then they do end up hurting others. Certainly I've worked with a lot of people who have harmed or killed their loved ones when they were extremely psychotic, done things that when they have been medicated, they have been absolutely horrified that they have done, and it's just very heartbreaking.
Yeah, that would be difficult. And I have known people as well who, when they're doing well, when they are following their care regimen, they really don't want to go in that other direction. They, please don't let me do that again.
Yes.
Once they're in that other space, once they're being, not doing self-care, not doing what they need to do to feel well, then they don't, they dig their heels in and they want to stay there. It's a sticky one. So moving along, what did you observe over the years about mental illness and substance use? A lot of overlap there, obviously. And what impact did the war on drugs have on your patients?
That is a good question. North Carolina, I thought was, and I don't know, I worked with a lot of people in close custody. So I did minimum custody work and a good chunk of medium custody work where I saw patients. But usually when I looked at people's prior arrest records and their current charges, a lot of them were not in, at least for just possessing the drug or using the drug. I mean, certainly we work with people who sold the drugs or distributed the drugs. So my general impression is I did not necessarily feel that North Carolina was locking people up just because the person was a drug user. So that always made me feel better. I mean, there was usually another crime associated with it, a property crime or whatever, because I believe there are some states, you use the drug and boom, you're in prison or jail. And then of course, they North Carolina back in the 90s did start the drug treatment court initiative, which I think is very helpful, you know, realizing that addiction is a disease and you don't want to punish somebody for a disease, and also just trying to get them the help so they could recover.
Mm-hmm. What was your role in forming the mental health or the drug courts?
I was hired on a Governor's Crime Commission grant to be the drug planner researcher for the Administrative Office of the Courts. I think I started in 1995. And so we developed a a substance abuse in the courts task force to see how the court system could help the executive branch or whatever with the whole drug problem, because of course we were getting a lot of drug charges of various sorts. And so it was a very big task force, and we had a number of people on it. We had legislators on it, both from the House and the Senate. We tried to be bipartisan, so we had, you know, some Republicans and some Democrats, and we had some people from the various different executive branch departments, like the prisons and Department of Public Instruction, and certainly DHHS, and just all these people, former people who had addiction problems. And so it was, I don't know, maybe a 30-person task force. And Bob Ward is a public defender in Mecklenburg County, and he was the one who really spearheaded the whole idea of the drug treatment court, and was very enthusiastic about it. And the whole task force decided to go with it. So we went to Florida, where they had started one. We went to Las Vegas, where they had a big conference. And drug treatment court is where the prosecutor, the defense attorney, and you know, other people all work as a team to try to get people treated rather than imprisoned. And so North Carolina, I thought, did an excellent job of carrying through that initiative. And of course, there are still drug treatment courts. And now there are mental health courts, or, you know, juvenile justice courts, or social justice courts, where, because I think we have a few of those. And so it's just a really neat thing. And it was so neat to see it in action.
Mm-hmm.
A couple times I was able to.
It is exciting. I've met people as well who have come through either a mental health court or a drug court. Mostly these are my Ohio contacts, but
Mm-hmm.
the sense of liberation they have if they complete the program and all goes well, it's a pretty beautiful second chance. So
yes,
it sounds pretty wonderful
and really needed.
Yeah, absolutely. And we'll do one more question before we turn to our video of the week. What do you wish more people knew about incarcerated individuals who live with mental illness?
Okay, let's see. What did I say about that? I think I did it. First of all, I just did incarcerated people in general, because I guess, I mean, there are some, I think the thing to remember is that they are people, and that to me, there's always hope that they can change their behavior. So I've worked with some very antisocial, psychopathic people, but you know, I think it really helps to help them see the good in themselves, and to treat them like a human being, and that there's a lot of power in that. So that's just, let's see. Oh, and one thing I do want people to know just about incarcerated people in general is I do feel somewhat strongly that it could be any of us who could end up behind those bars, because you just never know when somebody is going to hurt your child or your loved one, or you're just wrongly arrested. I mean, you just never know what's going to happen. And certainly I had a number of people tell me, I never thought I'd be here. You know, I was one of those ones who just, you know, thought incarcerated people, criminals were horrible, and they had no empathy, and then they end up being there. So I think that's, you know, something important to remember. But as far as what I want them to know about mental illness, the whole idea that mental illness oftentimes is a brain disorder and a neurotransmitter disorder. And so it's not something that people could just, you know, buck up and feel better, or, you know, get themselves together and not be psychotic anymore. Because if somebody, you know, had diabetes, you don't say to them, well, you know, change your attitude, you know, buck up. And not that there aren't things to do with diabetes, like diet and exercise, but people just forget that it's a brain disorder, and because of neurotransmitters, it just, that things are awry, and it's a biological illness. Likewise with depression. So that's one of the things I think both, you know, incarcerated or not, that they'd think about. And with the North Carolina prison system, I guess I would like them to know that there are a lot of dedicated people there who really, really care about the people they work with, and are there because they want to be, and work just incredibly hard to see everybody and to take care of them and to make sure that they're okay.
Well, I agree with so much of that, or all of it, I guess, because it is easy to forget that we're all on a continuum. And for myself, as a younger person, I had some substance abuse, unfortunate substance use moments. And I was lucky. I should have had a drunken driving arrest. Honestly, I should have. I could have easily ended up at the wrong party at the wrong time. But I remember a month where several weekends in a row, I just walked out of a scene where the police showed up later. Wow. Surprised my friends didn't think I was calling them. Honestly, it was just weird. And so as I look back and I think of just these serendipity moments, and I also think, well, you know, I'm a person of privilege, not enormous privilege, but, you know, had I been a person of color, how would that have gone? Would I have walked between the raindrops then? I don't think so. So I really appreciate what you're saying. And I just think it's so important to realize that the walls that we perceive between human beings, they don't have to be there. So thank you for that. And now we're going to take a quick turn to our video of the week. Before we do that, I want to wrap up the interview. I want to thank our folks working behind the scenes, psychiatric nurse Gail Pruitt for handling Facebook, and executive director Gary Kreitz for always being there and working the chat box. And Gail also referred Tricia. She connected Tricia and myself. So thank you for helping this show happen. Very, very helpful. And now we're going to move on to our video of the week. We're going to go with something light. Some of our topics on Thursdays with NAMI are a little bit heavier. So we're going to do a walk down memory lane with former NAMI North Carolina mascot, Roxy Morrison. And, all right, here we go. So that was a fun diversion. Did you all see the video?
Mhm.
Okay. Once in a while, something goes awry and that doesn't happen. So now it's time to take questions from you, members of our virtual studio audience and folks on Facebook. And we had a question from earlier that was in the chat box that I want to bring up. It sounds like this person is an attorney. I have read expert opinions that refusal to rejoin community can be a result of years in isolation. Do you agree it is not normal to choose to be in solitary confinement?
Y- Yes, I do agree it is not normal. Some of the people do have the mental illness that makes them, even if they were out in the community, they'd be isolating, but maybe in their bedroom instead of a prison cell. With other people, some of it is of course fear. Some people are afraid to go out into regular population. Prison can be very tough. And so that is also not necessarily normal. Some people just don't want to take their chances out there.
Mhm. Right. Okay. And we've got some more questions lined up. This is from Bob. While American Rescue Plan dollars are restricted from being used from programs that are institutional or long-term residential in nature, assisted outpatient treatment, or AOT, does meet the criteria for funding. Do you support AOT? And I want to make sure people understand what that is. AOT is assisted outpatient treatment. It's similar to involuntary commitment, but different. The person remains outpatient if they have a solid track record for certain behaviors leading up to them becoming a harm to themselves or others. Then they can basically have mandated treatment. They can have treatment mediated by a judge because of that track record, and people who care about them, presumably, are surrounding them and trying to get them into care before they reach that point of being in real trouble.
Yes, well, I strongly support outpatient treatment in general. I like the ACT teams where they try to keep people in the community, make sure that people have housing, because housing is one of the key things. Just getting transportation and getting their medication. I mean, if we did more outpatient, that would just really help a lot of our problems. And I also do like the idea of the medications being court ordered sometimes, that they actually are involuntarily medicated, especially if they have had a past history of being dangerous to others, being dangerous to themselves, and then they become psychotic and really have a hard time making the decisions for themselves. Because it is sad to know that people, you see people who are psychotic, and then of course I get the chance to see them when they're not, and how regretful they are about some of the things they do. But it's just, as I said, the nature of the disease. So if the more we could do outpatient well, the better I think society would be. But unfortunately, we have to wait till the problem is very bad before we intervene a lot of times.
Mm-hmm. And I'd like to point out too that this corresponds to our discussion on deinstitutionalization. I think once upon a time it was very easy, way too easy, to commit someone to care against their will.
Yeah, that's bad too, right?
Right. It's so ripe for exploitation.
Mm-hmm.
But today, to let someone get to the point where they have to be a clear danger to themselves or others, someone can do a lot of damage before they hit that point. Having said that, I also want to point out that the peer community would say that assisted outpatient treatment is another way of saying forced treatment. They're generally against it, a lot of the peers and peer advocates. So I want to acknowledge and honor that perspective and that
Yes.
experience. I kind of sit in the middle. I'm a family member and a peer as well.
Mhm. And in many cases, I could certainly support that, but with some of the people I have seen, who are just so dangerous when they're psychotic, and what's sad is that many times they end up killing their loved ones who are taking care of them, and then they, once they're medicated, they have to live with that. So, and believe me, I am not advocating involuntarily medicating every single person with schizophrenia. I do think the criteria are very important. Imminent danger to yourself or others is what we use, or the decompensation is such that very soon you will be of imminent danger to self and others, because we know people who are fine when medicated, but some people will just, boom, they'll go back to their psychotic state within one day. Some people, not for a while. And so, getting to know our patients, it is a help that way.
Right, exactly. So I think we've covered a lot of angles on AOT, assisted outpatient treatment. A question from Gary: because a large number of mental health patients are incarcerated, how does a therapist have the time and opportunity to build therapeutic relationships?
That is a very good question. It's very difficult, especially when you don't have enough staff. The prison staff for a while is, I used to know the figures for this, but we haven't gotten a lot of staff in the last at least 10 years, maybe longer than that. And so some of our clinicians have a very, very large number of patients. And making a therapeutic relationship could sometimes be hard, but when a prison is backed up, sometimes I would go in to help. And so I wouldn't know any of the people. So I had to make a relationship fairly quickly. And just looking like you're going to take your time and listen to them. It's amazing how, even though you're thinking, I've got to see 8 people this morning, I really only have 20 minutes or so, that if you just listen to somebody for a good 15 minutes or so, which is really not that much time in a session, they really feel heard, and they get the opportunity to just sort of say what they want. Also, I do feel it is better to take handwritten notes. When you've got that many patients, sometimes it's tempting to get on the computer, but I also think that to make relationships, it's really nice to just, sit, because I can write my notes without looking down. Well, I can sort of type without looking down either, but because I don't, but then, your computer's clicking and all that. And I think that's a nice way to make relationships, but to me, it is listening, being able to just sit and listen to somebody.
That makes a lot of sense to me. Listen and find an unobtrusive way to take notes, probably without a computer. Interesting question. Do you know why the United States has the most people in prison compared to other countries, industrialized countries?
I actually don't. I'm sure it has been studied, but I don't quite know. I mean, part of it I do believe was the earlier war on drugs. A lot of it is because many other countries do have better gun control, and I certainly don't want to insult anybody who has guns, but I mean, it does make it more difficult. I think because we're an individualistic society, that sometimes we don't look at the collective. And so I think there's more conflict, and we do have gangs. And also healthcare might be one reason, a lot of places where people can get their healthcare, that makes life a lot less stressful in a lot of ways, and people don't get in trouble. And of course, our alcohol and other drug use is even though it's not they're not incarcerated for a drug crime, you know, there are the property crimes, the drunk driving crimes, the violent crimes. And I think we are a fairly heavily substance using country.
Yeah, really interesting question there. We do incarcerate the most people. It is not a number to be proud of. It's not an area where we want to be best or first, but there we are. So thank you for that question. What are the pros and cons of mental health courts?
Mental health courts came into being before after I left, but I mean, you know, one of the advantages is it's in a way sort of almost acting like an ACT team, or I mean, it's with the, you know, with the, and with also with everybody working together, so that if somebody has committed an offense because of their mental illness, rather than putting them in prison or in jail, you work with them to, you know, with their providers and all, to, you know, get medicated, stop, you know, self-medicating maybe with alcohol and other drugs, and doing things to, once again, like substance abuse, putting them on the road of recovery from what is a disease and not just criminal behavior.
Right. And a question from Gail. Did you actually address therapeutic issues and provide therapy in the course of forming therapeutic relationships?
Yes, I did. I really liked dialectical behavioral therapy. A lot of people I worked with had trouble just with emotional regulation, so I would use those techniques. I found them to be very effective, not just for the people with the borderline personality disorder for which it was originally used, but just a lot of us just took various pieces of DBT and used them. I did anger management. I did work with a lot of close custody, but some of them still released. And then I did have medium and minimum custody patients. And I did a lot of relapse prevention work when they were going to go out back into the community, to think about, you know, what are their triggers, what's their relapse prevention plans. And I did a lot of cognitive behavioral therapy. I mean, even just in the whole, you know, I wouldn't necessarily do it formally, but when they would make certain statements, I would just, you know, use the cognitive therapy techniques to, you know, sort of change their cognitions, help them change their cognitions.
Absolutely. Cognitive behavioral therapy, good stuff. Something to Google, Dr. Marsha Linehan. And yeah, so we seem to have a lull in the questions right now. Go ahead and type them out. In the meantime, I'll make a couple quick announcements. Please fill out our survey when you leave Zoom. A survey will magically appear, and you can let us know how much you learned from tonight, what you liked, what we might have done differently. That helps us improve over time, and it helps us show the value of what we do to funders, shows that we have some quality control. Next week, we've got suicide attempt survivor Sean Wellington of Chapel Hill. Excellent storyteller. He brings people together to share stories of survival on his podcast, Suicide Noted. He's also the speaker and founder of Grit, True Stories That Matter. And he does a wonderful job facilitating conversations and storytelling around mental health, around topics that challenge people and that people find difficult. So please join us next week and meet Sean Wellington. I see we've got another question. What is your opinion of North Carolina law that a person who acts out in a mental health crisis while in an emergency room can be charged with a misdemeanor or even a felony?
I guess the charging is not that bad, because I mean, it's hard to know whether they truly have a mental illness that would interfere with their ability not to have acted out. And so you don't want people with just temper problems, or, you know, they're drunk or whatever. Not that alcoholism isn't, or, you know, a disease, but you don't want anybody to go into an emergency room and just be rampaging all over the place, or misbehaving, because it's a hard enough place to be anyway. So I don't see anything wrong with it, because once they get the charge, then they can, you know, bring up their mental health stuff, or maybe get to a NGRI. And certainly there are many cases that, even though people have a mental illness, that doesn't mean that they at that particular time were out of control or doing their behaviors because of the mental illness. And so you have to tease that apart too. So just like people without mental illness could be charged for something like that, I don't see anything wrong with people with mental illnesses being charged, but their defense might be a little bit different.
Okay.
If I'm answering that correctly. Or
I believe that was that law was recently implemented or amended. I think that's why it's come up. Our policy director would have the full scoop on that. I will follow up with anyone who's interested and get some information on that. Again, we do have a little bit of time. Thank you, Bob, for typing in the chat box the elements that are studied in DBT, dialectical behavioral therapy: mindfulness, emotional regulation, interpersonal effectiveness, distress tolerance. Are there more, or is it just those four?
It's those. I just did that slide yesterday for my class. So those are the four main ones.
That's right. Good stuff. Dialectical behavioral therapy. All right. Well, I don't see any questions. Do you have any closing thoughts you'd like to share with us, Dr. Hahn?
No, I just thank you all for all that. I know a lot of you are doing stuff out there, and really trying to, you know, make sure that the rights of people with mental illness are taken care of. And also, of course, I know that NAMI looks at diversity issues and a lot of other issues. And so I just think that's great.
Well, I really appreciate your taking your time to spend with us tonight, your insights, and it's been a wonderful experience for me. Thank you so much.
You're welcome, and good to see you. Will the chat be left up for a little bit? Because I didn't have a chance to read the comments, and I'd just be curious, or when you close out, does it go away?
I don't have to close out right away. I'll just, we'll wrap up. I want to thank everyone for being here with us tonight. Have a wonderful week ahead, and I hope to see you next time. In the meantime, be safe and be well, be kind to one another. So I'll just sign off with my video and mute, but we'll leave it up for a minute, okay?
Okay, thank you. I'll be quick.
Sure. Thank you again. Take your time.
Thank you, everyone. It was a pleasure working with you and everybody.
Likewise.
Oh, God.